In this chapter, we'll be dealing with the anatomy of a long bone and healing of a fracture. So, bones may be classified into four types on the basis of their shape, that is, long, short, flat, and irregular. So, first, discussing the structure of a typical long bone here. We have the epiphysis, so two ends in children, and an intermediate part called the shaft or diaphysis. Okay, the part of the shaft which is adjoining the epiphysis is called the metaphysis. There is one metaphysis next to each epiphysis. Okay, and separating the epiphysis from the metaphysis, there is a thin plate of growth called a epiphyseal plate. It is a thin plate of growth cartilage. Okay, so the bone growth occurs at the epiphyseal plates lengthwise. So at maturity, the epiphysis fuses with the metaphysis, and the epiphyseal plate, also called the growth plate, it is replaced by bone. So epiphysis which does not contribute to the growth of the length of the bone is called apophysis. Okay, so the articular ends, they are covered with of the epiphysis, they are covered with articular cartilage and remain so throughout the life. Rest of the bone is covered by periosteum, and this provides attachment to tendons, muscles, ligaments, etc. The strands of fibrous tissue connecting the bone and the periosteum are called Sharpie's fibers. So microscopically, you have woven bone or lamellar bone. So woven bone or immature bone is just woven immediately after a fracture or something, like not immediately, but after a fracture or something like that. It is in the initial stages of fracture healing. It is woven bone is formed at periods of rapid bone formation. There is random arrangement of bone cells and collagen fibers. Lamellar bone or mature bone has an orderly arrangement of bone cells and collagen fibers. See, both cortical and cancellous bones are made up of lamellar bones. The only difference being the way the lamellar bone is arranged. So loosely in cancellous bones and compactly in cortical bones. So the basic structure of the bone is the osteon. So you have central Haversian canals. Okay, so concentric lamellations are lamellae surrounding a central canal, so Haversian canal, and then they are connected transversely by Volkmann's canals. So the Volkmann's canals run horizontally from the endosteum to the periosteal surfaces of the bone. So the shaft of the bone is made up of cortical bones, and the ends are mainly made up of cancellous bone. So the junction between the two, the cortico-cancellous junction, is a site where fractures commonly occur. So structural composition of the bone, you have bone cells and the matrix in between them. So the matrix consists of two types of materials, organic and inorganic. Organic is formed by collagen protein. So it is 30 to 35% of the dry weight of the bone. Inorganic is mainly calcium and phosphorus salts, especially calcium hydroxyapatite. It constitutes about 65 to 70% of the dry weight of the bone. And then moving on to the cells. So we have osteoblasts, which are concerned with ossification. They are rich in alkaline phosphatase and glycolytic enzymes and phosphorylases. Alkaline phosphatase, that is important. And osteocytes, which are mature bone cells. So they vary in activity and they are rich in glycogen and they have positive granules. And osteoclasts are concerned with bone resorption. They have hydrolases, collagenases, and acid phosphatase enzymes. So growth of the long bone. All long bones, they develop from a cartilaginous model. So endochondral ossification. So this commences in the middle of the shaft before birth. So this is called the primary center of ossification. The secondary centers of ossification appear at the ends of the bone at the epiphysis, mostly after birth. But one exception is that the epiphysis of the distal end of the femur is present at birth. The bone grows in length by continuous growth at the epiphyseal plate, but the increase in girth is by subperiosteal new bone deposition. So at the end of the growth period, the epiphysis fuses with the diaphysis and the growth stops. So presence of the epiphysis, its time of appearance, fusion, all of this has a relevance in deciding the bone age of a child. So an epiphyseal plate may sometimes be wrongly interpreted as a fracture. So the remodeling of bone, it follows the Wolff's law. So Wolff's law basically tells you that bone hypertrophy occurs in the plane of the stress. Okay. So blood supply of long bones. So basically you have a nutrient artery which enters the bone, and then it runs to either side, either end. So each of these further divide into a leash of parallel vessels which run toward the respective metaphysis. Okay. And then you have the metaphyseal vessels. Again, they're found by the anastomosis here. So they supply the metaphysis. Epiphyseal vessels, they enter the epiphysis directly. And then periosteal vessels. So the periosteum has a rich supply by short periosteal arteries. So the periosteal arteries, they supply the outer one third of the bone. The inner one third is supplied by the nutrient vessels. Next, moving on to fracture healing. So the healing of fractures is in many ways similar to the healing of soft tissue, except at the end of soft tissue healing, the result is fibrous tissue, but that of a bone healing is mineralized mesenchyme, which is bone. So fracture healing means the way a fracture heals in a natural or non-operated way. So first, you have to remember that there is a stage called the stage of soft callus till when one can play with the fracture, change its alignment and all that. But after a certain stage, this is not possible to do so. So any further desired change in position can only occur by intervention, that is by breaking the healing fracture, which is called osteoclasis, or by formal opening the fracture and cutting it with instruments, which is called osteotomy. So these are the stages in which the fracture healing occurs. Stage of hematoma, fibrocartilaginous callus formation or soft callus formation, bony callus or hard callus formation, and then stage of bone remodeling. So starting with stage of hematoma. So basically what happens is, whenever there is a fracture, the blood vessels at the site of the fracture are injured. So there is bleeding. Okay, this collects in the form of a hematoma. What happens is, when these blood vessels are injured, the fracture ends. They are not supplied by blood anymore. So there is marginal necrosis of the fracture end and the surrounding tissues. So that is why often the gap between what was a crack fracture, it appears increased after a few days. So because when all of this blood and this marginal necrosis, what happens is, because of all this, there is a lot of debris that needs to be cleared out. So inflammatory cells, they come and try to clear out all this inflammatory debris. So these red tissues, they cause the secretion of pro-inflammatory cytokines like TNF alpha, bone morphogenetic proteins or BMPs, and interleukins IL-1, 6 and TNF alpha. They are mainly important. So these cytokines, they attract the macrophages, monocytes and lymphocytes. They scavenge and remove the necrotic debris. So these cells also secrete VEGF to stimulate healing at that site. So because there's a lot of inflammation and marginal necrosis, all that is being cleared out, and there's an increased gap. So the fracture is still very much mobile at this stage. Okay, and then what happens is, there is a stage of soft callus formation. See, the first 5 days you'll have bleeding, stage of hematoma, and all the necrosis happens, and you have lots of inflammatory cells coming in and secreting VEGF. 5 to 11 days, what happens is, the VEGF which was released, it leads to angiogenesis at the site. So within the hematoma, there is a fibrin-rich granulation tissue. All the fibrin in the blood in the hematoma, it kind of collects, organizes, and forms granulation tissue, and that begins to develop. So further mesenchymal stem cells are recruited to the area. They begin to differentiate into fibroblasts, chondroblasts, and osteoblasts. And as a result, they lay down a collagen-rich fibrocartilaginous tissue spanning the fracture ends. So at the same time, what happens is, woven bone is laid down. So woven bone, it is the earliest sign of fracture healing when you see a cloud-like appearance on an X-ray after a fracture. Okay, it usually occurs at 2 weeks from a fracture. So it appears much earlier in children. So because of woven bone, it is still irregularly organized bone, right? The lamellae are not regularly organized. So that is why the fracture starts becoming sticky because of woven bone. It is still possible to change the alignment of the bone by gentle manipulation. Okay, so you can see here, what happens in the first 5 days is fracture and necrosis, cytokines are liberated, there is a stage of hematoma formation, all these precursor cells are sensitized in the hematoma stage, and the fracture is still very much mobile. There is an apparent increase in the gap of the fracture, etc. In the stage of soft callus formation, what happens is, the hematoma which had formed, the fibrin sort of gets organized, it forms granulation tissue, all the cells start coming in, chondroblasts, osteoblasts and all that, and the VEGF causes angiogenesis and neovascularization, and there is woven bone laying down. Okay. Next, you have the stage of bony callus from day 11 to 28. So from the first third of the month to the last end of the month. So what happens is, the cartilaginous callus, the soft callus, begins to undergo endochondral ossification. So the cartilaginous callus starts resorbing and begins to calcify. So subperiosteally, the woven bone continues to be laid down. The newly formed blood vessels continue to proliferate. They cause further migration of mesenchymal stem cells. So at the end, the soft callus, it becomes hard callus. Okay, this is called a bridging callus. Okay, because it kind of bridges both the fracture ends between the two bones. So it is a sign of progressive bone healing and can be clearly seen on x-rays. Over a period of time, the bridging callus becomes more and more solid. So by this time, the fracture has gained enough strength, and now if you try to change the alignment, it won't be easy. So you'll have to break the healing bone, break the bridging callus, healing bone. So this is called osteoclasis. And then finally, you'll have something called a bone remodeling, which occurs from day 18 onwards and lasts till months or years. So the hard callus, it undergoes repeated remodeling. So it occurs in a block by block manner, and it is termed coupled remodeling because osteoclast activity and osteoblast activity is coupled at the same time. So the center of the callus is ultimately replaced by compact bone, while the callus edges become replaced by lamellar bone. So this can be seen on x-rays as what was callus turning into dense white bone akin to normal bone. So Wolff's law plays an important role here. So bone changes its shape according to the stresses it is subjected to. So the process of bone remodeling lasts for many months, ultimately resulting in the regeneration of normal bone structure. So that is why sometimes the remodeling is so effective that you cannot even distinguish an old, that you cannot even find an old fracture on an x-ray. So the process of bone healing or ossification is also called endochondral ossification. So first the collagen-rich cartilage cells are formed, then they are replaced by immature bone. So this occurs during the formation of long bones in the fetus. So first they are cartilaginous, then they turn into bone. Then you also have something called intramembranous ossification, which especially takes place in the formation of flat bones of the skull. So the mesenchymal tissue, the primitive connective tissue, it is converted directly into bone with no cartilaginous intermediate. So then you have healing of cancellous bones. So see, it follows a different pattern because the cancellous bones are uniformly spongy in texture and they have no medullary cavity. So there is a large area of contact in between the trabeculae. So the direct union between the bony trabeculae can occur. Subsequent to hematoma and granulation tissue formation, mature osteoblasts, they lay down the woven bone in the matrix and the two fragments unite. There is direct union also which can occur. Then you have primary and secondary fracture healing. So basically you have to remember the differences. So primary healing is direct healing from bone to bone. There is no intermediate callus formation. Secondary healing is that, in secondary healing, you first have callus formation, then that becomes bone. So bone to bone healing. So direct bone to bone, callus, and then bone to bone. See, primary healing, you have to anatomically stabilize the bone. So there is rigid immobilization, absolute stability. Whereas in secondary healing, there is relative immobilization or relative stability, such as within plaster, etc. So primary healing is possible only by surgical fixation of the fracture. You are anatomically putting it in the proper place. Whereas secondary healing, so when you are treating the fractures non-operatively in most cases, so in those conditions, and also in fractures such as comminuted fractures in which there is micro motion at the healing site, so there will always be secondary healing. So that is what is described here. So the prerequisite for primary healing is that bone ends have been anatomically reduced. There is no gap at the fracture site. The fracture has been rigidly fixed surgically and there is no micro motion. So it is absolute stability. And then factors affecting fracture healing. So first, age of the patient. In younger children, the callus is often visible on x-rays as early as 2 weeks after the fracture. So bones in children unite in half the time compared to adults. So then you have nutritional status, metabolic disorders such as diabetes and hypothyroidism, which delay fracture healing. Nutritional status, hypoalbuminemia and vitamin deficiencies, all of them, calcium deficiencies, vitamin D deficiency, all of them, they decrease fracture healing or they slow down the fracture healing. Smoking and alcoholism. Then you have fracture factors. So first, the type of bone. Flat and cancellous bones, they unite faster than tubular and cortical bones because again, cancellous bones, the bony trabeculae are directly united. And then pattern of fractures, so spiral fractures unite faster than oblique, which unite faster than transverse fractures. Then mechanism of injury, again low velocity and high velocity. See, the difference in the behavior of low velocity and high velocity injuries is in the fact that there is a different level of soft tissue injury which is associated. So fractures with more soft tissue stripping lose blood supply of a larger segment of bone. Hence, it takes more time for the bone ends to revascularize and for the bone to unite. And also disturbed part of anatomy. So soft tissue interposition or ischemic fracture ends. Because of all of this, the bone healing is delayed. And then open fractures, they're often going to delayed union and null union. So Surgeon factors, again, type of reduction. At least, see, basically, good apposition of the fracture results in faster union. At least half of the fracture surface should be in contact for optimal union in adults. In children, a fracture may unite even if the bones are only side to side in contact, so which is called bayonet reduction. Then immobilization. It is not necessary to immobilize all fractures such as flat bones like ribs and scapula. They heal anyway. Some fractures need strict immobilization and may still not heal. Stable fixation. So whenever surgery is done, stable fixation is important. This could be rigid fixation wherever possible, and you aim at primary healing, or at least a stable fixation and achieve union by secondary healing. Some additional information. So the pathognomic sign of traumatic and fresh fracture is crepitus. So most common cause of non-union is inadequate immobilization. So markers of bone formation, you have alkaline phosphatase, so serum bone specific alkaline phosphatase, osteocalcin, and serum peptide of type 1 collagen. Then markers of bone resorption, you have N and C telopeptides of urine and serum cross-linked N and C telopeptides. And then so you also have urine total free deoxypyridinolin, so pyridinolin. And then rate of mineralization, it is determined by labeled tetracycline.